Okay, so let me begin this event. I'm Manfred Phillip. I'm happy to be involved in our event, the Pandemic and Managing Public Health Crises, Updates and Appeals from Nepal. I'd like to start out by thanking some people who helped make this event possible. First of all, Mary Kirk of the State Department's Bureau of Educational and Cultural Affairs created some contacts that made this very possible. And so Mehthild Schmidt, a professor at New York University, was very helpful in making contacts. Armin Babanjanian of the World Affairs Council of San Antonio, Sarah Danielson of the CUNY Academy, Joel Escobar of the Bell Zeller Fund, Alicia Georges of the Nursing at Lehman College, Andreas Dewald of Fulbright alumni in Germany. And for the Fulbright Association, there are quite a few people who have been very helpful. And they are Christine Oswald, Tom Agustin, David Smith, Trey Gwynn, Miranda Panzer, and Patrice Moulton have all asked their members to join in. And then there's Louisa Burrell and Sumana Chandra of the CUNY School of Public Health and the US Embassy in Nepal. And so I'm happy to turn this over to Rashu, who is our head of our Fulbright Association and Commission in Nepal, and it's all yours. Okay, Rashu.
Thank you, Dr. Phillip. Thank you everyone for joining us here today. It's an extraordinary moment to have a community from all over the world join us to hear about Nepal and also hear from our frontliners. I am usually really good at extempore, but to keep to brevity and let our main guests get their time and fair share to present the situation in Nepal, I'm going to present a written speech quickly with some amount of sobriety because Nepal is going through a very hard time. The pandemic has affected the whole world. Friends and colleagues who have gathered here today understand this well, I know. Still, I want to acknowledge the stresses on our personal and professional lives and the challenges that each of our countries, economies, organizations, families have faced in the last couple of years. Yet I think most of our challenges compare little to those of the frontline workers, the doctors of the world, the nurses, the custodians of healthcare systems and emergency frontline workers who have applied themselves tirelessly to the service of the very sick during these unprecedented couple of years ravaged by COVID-19. With deep gratitude to their service, I am proud and honored to have Dr. Sangeeta Mishra, Dr. Biraj Karmacharya, Dr. Archana Shrestha, and Dr. Sri Krishna Maharjan, all Fulbright Program alumni, but experts and specialists in their own right, here today to provide an update on the impact of the pandemic on Nepal. They will also add to the appeals to the global community for collaboration and support that will help us come out of these catastrophic circumstances we find ourselves in today. You will hear each of them in a few minutes. I do want to draw your attention to the fact that while this seminar is meant to be substantive in facilitating the understanding of the scale of the challenges faced by Nepal and how it is coping, in no means it is meant to be comprehensive. We understand that the challenges faced by rural communities, towns and cities across Nepal that do not have institutions like Patan Hospital, Dhulikhel Hospital, or Parupakar Maternity and Women's Hospital face even more dire circumstances. However, each one of the panelists and the hospitals that they represent work tirelessly from within their networks across Nepal's public care delivery points and have forged remarkable community health programs in collaboration with local partners to serve the needs of the communities at the margins. I also want to acknowledge the presence of more than 300 registrants and attendants, hopefully by the end of today, our US and other international partners, scholars, researchers, policymakers, leaders, and politicians who've joined us here today. We count on each of you and your leadership to take meaningful action to help us strengthen the public healthcare system in Nepal and call on those of you who have special access to national decision-making and regulatory controls to call out and stop mismanagement and corruption where you see it becoming a major roadblock to life-saving service delivery. As Arundhati Roy has said, we need to treat this pandemic as a portal to understand deeply the common plight of humanity and be courageous about making necessary and radical shifts for a more equitable, socially just, and a healthier world. I have every trust you have joined us here today in that spirit, and I'm thankful for your presence here. I'm especially thankful to Dr. Manfred Philipp, Professor Emeritus of City University of New York, our moderator today, and an accomplished biochemist who was a Fulbright Scholar to Patton Hospital in 2012, who wrote in with a message to help Nepal be heard across the global community at a time when we were going through the roughest patch of the second wave. His nudge and leadership at a time when we were feeling really low made this event possible. And that is how the Fulbright program, as a program that creates global community, has enabled us here in Nepal. We are hopeful that the outcomes of our engagements today will build the base of lasting impact on improvements to public healthcare in Nepal. Without further ado, I want to invite the acting chair of the board of the Fulbright Commission, the Public and Cultural Affairs Officer of the US Embassy in Nepal, Carl Rogers, to say a few words. The Fulbright program is in its 75th year around the world, but the Commission of the Educational Exchange between the United States and Nepal is in its 60th, a seminal time, and it is led by equal representation of US Embassy and Government of Nepal representatives and civil society leaders, and is committed to educational partnerships, people-to-people understanding, and exchanges of expertise between the US and Nepal. But at events like these, we reach out to the global community of our fellow researchers, scholars, partners, friends of Nepal, and we are happy to have you here today. And I invite you to please listen to Carl, the leader of the Fulbright Commission's board. Thank you.
Thank you, Reishu. Good evening or good morning, depending upon where you are, and namaste. As Reishu said, my name is Carl Rogers, and I'm a public affairs officer at the US Embassy in Nepal. And I also have the privilege of overseeing the Fulbright Commission. So day in and day out, I have a front row seat to the incredible impact that Fulbright has here in Nepal. That's due to the hard work of Reishu and her team. It also has a lot to do with Fulbright alumni, which many of you on this call are, and we have the privilege of listening to many on our panel tonight as well. So let me just start by saying thank you. Thank you for being here. Thank you for participating. I'll say, in addition to my work with the Commission, I also get the privilege of working with all of the alumni from the United States exchange programs. And I do have to admit, though, that the Fulbright alumni are some of our best. Not only do Fulbright scholars at all educational levels represent the talent and the perseverance of the Nepali people, but when Fulbrighters return to Nepal after their study in the United States, they are the leaders. They are leaders in their fields and they're leaders in their communities. So particularly when I look back at the last 17 months, I am really proud to say that Fulbright alumni have been some of the first and some of the most prominent Nepalis to respond to the COVID-19 crisis. They've worked on the government response, enacting regulations, advising policy. They've also founded clinics and quarantine centers. They've reached out to contacts that they made while they were Fulbrighters in the United States, which has given them real insight and given them opportunities for advice and connection that has helped Nepal navigate this crisis. So Fulbright alumni have worked on the front lines, and I know that they've also been fierce public advocates. But no matter what role they've taken, I have to say that it is their expertise and their generosity that has truly saved lives here in Nepal. It's really just inspiring to see the role that they've played. I also just want to take a brief moment to acknowledge that the last couple of weeks have been especially difficult here in Nepal for the government and for the Nepali people. And I will say that the United States Embassy is proud to continue to support Nepal and Nepalis as we have for the last 73 years. Since the beginning of the COVID-19 pandemic, the United States mission. So the State Department, USAID, and the Department of Defense have donated more than $51 million in life-saving assistance, including medical supplies, testing supplies, ventilators, oxygen cylinders, PPE, and much, much more. We continue to work very closely with the government of Nepal in order to identify and to provide the assistance that's necessary in order to beat this pandemic. And as many of you know, President Biden announced on June 3rd that Nepal will be among the first countries to receive vaccine donations by the end of this month. So while the White House is making those final determinations regarding vaccine donations, I do want to remind you that this is only the beginning, that the United States is working with US vaccine manufacturers and companies to increase vaccine productions as part of our global strategy to defeat COVID-19, as well as other future threats. So I will just say that the United States has been a steadfast friend of Nepal's during good times and during tough times. So we will continue this support. And finally, I just want to also say that the Fulbright is celebrating its 75th anniversary this year. And when you look at the leaders in academia and business and in government, Fulbrighters have helped to make Nepal more stable, more secure, and a more democratic country. So I have no doubt that this program has helped shape incredible change in Nepal, and not just during COVID. So I do hope that you will join me in wishing Fulbright a happy anniversary. And I will also just wish that you and your families incredible health and safety as we continue to weather this storm together.
Thank you, Carl. Dr. Philip, over to you. We can't hear you, sorry.
Okay, I'm sorry. At this point, I just want to thank Ravi Khanna of the Nepal German Academic Association, who also helped co-sponsor this. I didn't neglect to enlist him before, but at this, I think Reshu, you should continue to moderate this meeting. You're better off that.
Okay.
Okay. Thank you.
Okay.
Thank you so much.
I will now call upon our first speaker, Dr. Sangeeta Mishra, the director of Paropakar Maternity and Women's Hospital, also a representative of the Government of Nepal, Ministry of Health and Population, to present from her point of view the context of Nepal at the moment, the challenges being faced all across Nepal in multiple regions, and the work that she has been doing, the gaps and the opportunities. Thank you.
Hello and namaste to everyone. My name is Sangeeta Mishra, and I will like to talk today about the first wave and the second wave of Nepal. I had an opportunity to work in two major hospitals in the Nepal, situated in one in the far eastern region and the another one in the central region. And I bring those experiences to you. So first of all, I would like to take you back in January 2020, when the first case was diagnosed in Nepal. It was 24th of January, when a student from Wuhan had come and he was suspected to have COVID. I would like to tell that at that time, we didn't have a PCR facility in Nepal, and we had to transport the sample to Hong Kong and get it confirmed. Soon after the confirmation of the case, country started thinking about its plan, how to curb the infection. And in this, at this point of the time, government decided to do the temperature scanning. Thermal scanners were placed at international airports and at some of the checkpoints at the borders. However, while it was going on 3rd of March, government of Nepal, they chose 25 hospitals to start fever clinic or start initial response. I would like to say at that time of point, we didn't had any resources. We could not get anything in the market, and there was a huge havoc in the country. So I started preparation according to the directives of Ministry of Health. And at that time, I was posted in Koshi Hospital, which is a 350 bedded hospital in far eastern region of Nepal. Uh, I was just 2 months over my in chargeship, and I was also quite new to the hospital as leadership role, and there was so much chaos all over the town, and nobody knew what to do. So the first challenge for me was about the PPEs, that is the personal protective equipments. There were no PPEs at all in the market. And we didn't had resources as well. I tried to get some PPEs, and at the most I could get only 10 PPEs, that too on the credit. And we didn't had any option rather than to innovate. So I started thinking about what can we do. So we started with using raincoats. So we could get 40 raincoats, and all these raincoats were shared between the healthcare staff in the emergency and in the wards, and they were actually reusing these raincoats. Then we used plastic and then some impervious material, cloth material, and we got it stitched from the garment factory, and we started giving it to the health worker. And we also stitch some cloth mask, which was used. But the main problem was the motivation of the health worker. Health workers were really scared. Nobody wanted to work. And there was huge pressure on the hospital. At this point of time, the private hospitals in the locality, they were closing down, and they stopped their services at that same time. And being a public hospital, I never had a liberty, and I never wanted to close the hospital. So at one time, we didn't had PPE. On the other hand, health workers were quite demotivated and scared. So it led me, and even health worker, everybody wanted to have a separate PPE and sanitizer. At this point of time, we didn't had any sanitizer. So I decided to make my own sanitizer. So it was again another innovation which I did. So according to the WHO guideline, I could buy raw material for the sanitizer, and I'm very proud to say that Koshi Hospital was the first hospital who could produce its own sanitizer, and which was taken by like it was followed by other hospitals in Nepal as well. Then the other problem was the resources and the coordination. Nepal has entered in this federal structure quite recently in 2015, and right now we have three-layered government: local, provincial, and central government. Koshi Hospital is a responsibility of, it falls under central government jurisdiction, while provincial government and local government, they have their own programs and they have their own policies. It was very difficult to coordinate with them, but I didn't had any choice. So I could reach out to them and I could convince them that we need to work along. Somehow I could convince them, and they were ready to work together. So we started, first of all, we started thermal scanning of all the patients who came to the hospital, because we just wanted to segregate these patients. Once after segregation, the other problem was if there was temperature, we had to do a PCR. And at that time, PCR was only available in Kathmandu, which was around 12 hours journey from Biratnagar. So that was another challenge. And the third challenge was where to keep these patients. Like if somebody has fever, you have to isolate them, then we didn't had a place. So we tried to make a small isolation ward, 6 to 8 bedded isolation ward. We collapsed one of our observation wards into isolation ward. But the other problem was the PCR thing. at that time, we didn't have resources, but we had one machine which was being used in doing viral load of for HIV patients. So we did some adjustment. Some of the instruments we could got from the veterinary laboratory, and somehow we started PCR, doing PCR at Koshi Hospital itself. And I'm really very proud to say again that this was the first public PCR lab outside the Kathmandu. After this, our problems were a bit solved, but the major problem was once you get COVID, where to keep all these patients? You cannot keep them in the hospital. And that led to an idea that we need a separate hospital. At that time, I could, with the help of local government and with the help of provincial government, the Ministry of Social Development, I could reach out to Chief Minister and asked for granting me one of the old building of National Trading Center, which was not used since last 15 years. And I just asked him like if we could use that building for making this COVID hospital, because there are chances if we cannot mix COVID positive and negative, and there will be a high risk of infection. Initially, Chief Minister was also like, he said, he was also not very convinced, but somehow we could convince him, and he said that he has to pass this building through in the cabinet, and that building was, that proposal was taken to the cabinet, and somehow we got that building. And then after that, we could involve the Army, Armed Police Force, Ministry of Finance, Province 1, and Ministry of Physical Infrastructure to renovate this building. So within 10 days, we could make a full-fledged COVID hospital, and we were actually ready. And at that time, when I was making, like we were doing this hospital was just 200 meters away from my home. So I had a huge, my neighbors were really very angry on us. And even like they were saying like, what is the use? Because everybody was panicked. So they just, they never wanted that COVID hospital should be in their neighborhood. So that was again another challenge for me, and it was really hard to convince them. After that, the problem was human resource. Nobody wanted to work. So we had to convince them, and I had to use different strategies. And different strategies included incentives, paid leaves, and then good quarantine facilities, and insurance. After that, some of the health workers, they said like, okay, we are ready to work. In between, while we were doing this in the hospital, we were in constant consultation with the local government and with the provincial government, because this border was suddenly closed. And that made another problem, because the border of Province 1 it's a porous border, and it actually two neighboring states of India, West Bengal and Bihar. It touches those two states. So the problem was that border was closed, but people were coming through other channels, because it is a very porous border. You can just cross the field and you could reach either India or Nepal, wherever you want to go. All these people, because India had already done a lockdown, and because in Nepal there are so many people who work as a migrant laborers, so they went to work, but when there was lockdown, they wanted to come back home, which is quite natural. But then there was a problem with the border, because the border was closed, and people were entering, and we lose track of all these people who were entering. So with the help of army, holding centers and quarantines were made in the local level, and army used to bring all those people from the border to the holding area, and according to their address, they were handed over to the local level, or local palikas, as we say in Nepali. So somehow we could manage the scenario in the first wave, and I would like to again point out that on April 17th, we finished making this hospital, COVID hospital, on 8th of April, and on 17th, first outbreak of Nepal was in province 1 at Udaipur district, and at the night 14 people were brought in, and all these people were Indian, and they were called Jamatis from the Muslim community. And suddenly there was a religious tension in the town, which we had to intervene, and we had to tell the police forces that this is going to happen, you have to intervene, and we could call all the religious leader, and somehow we discussed the scenario with them, and that situation was averted. After this, we could admit these patients, and these patients they were admitted, and I'm really happy that they were the best patients I ever had. They were really good, and we could take care of their food because they were quite isolated. We gave them phone, and we were constantly talking to them, and at that time they had fast that is called Ramzan, and we could provide everything for them, right from Quran to because the food pattern changes, so we could manage that. So somehow that was done. But the problem was that private sector had stopped taking any patients. So main problem was with the maternity cases, because women, the delivery cannot stop. So women were coming in, and there were cases when there were few hospitals that they just used to see the address of the woman or the patient, and if the woman was from the hotspot, as I said, the first outbreak was in Udaipur. So if the woman was from Udaipur, she was like refused, and we had instances when those women were directly thrown out of the operation theater or labor room. So I had an additional responsibility to take care, and I'm really happy to share that Koshi Hospital, while we never stopped any services, and parallelly we could run COVID and non-COVID services. While I was doing that in June, it's around for 5 months of doing all this stuff, I was transferred to another hospital as director, where right now I am working on. So I was transferred to Nepal's largest public maternity hospital in June. So when I came here, again the similar problem were there. So we didn't had a PCR lab, and we had to send a PCR to other lab, which would give report after 2 days, because sample load was quite high. So the main problem was with the PCR, because we couldn't delay the delivery. So again, with the help of local government, I started coordinating, because I had a very good experience in coordination, and I knew that it works. So I started coordination with the local government and established a PCR lab in July at Prasuti Griha, which was our hospital. And similarly, again, we again established another maternity care center for COVID positive women. And we did a separate OT and separate labor room and all facilities with the wards. We had a separate COVID positive unit for the women, and almost 140 women were admitted in the first wave, and almost 68 women delivered with by cesarean section or normal deliveries, and we did not lose any women at that time. So this was the first wave. The first wave, in first wave, we were actually very lucky because we had very mild cases, and it was like we could manage them. But what was happened in between, that caseload started decreasing. So once the caseload started decreasing, and then this lockdown was lifted in July, then people were back to their normal routine. And I must say that people forgot that there was COVID, or they were just like they were just confident. At that time, migrant labor again returned to India, and then again the marriages and the religious ceremonies, they started, and there was crowd. The public health measures were not taken, and again there was start of second wave. The second wave
Dr.
came,
Mishra, I'm going to ask you a follow-up question on this part of the presentation before you get to the second wave, maybe. With some juggling and management of time, I'm going to have to ask you to stop for the moment, but I'll make sure that I ask you the question on the surge in the second wave and where we've gotten. So if you don't mind, I will wrap up your presentation for now and move over. But I will be sure to ask you your side of your leadership role and how you managed maternity health and children's health and management of maternity situations from your leadership role in the second round of questioning as I come to you.
Okay, sure.
Thank you. Thank you. Yes, it's a very complex and progressive scenario of how the society has managed through this disease that in the beginning, nobody really had a sense of how to make sense of. So I think what Dr. Mishra is describing is Nepal getting caught off guard and even discrimination happening around COVID patients. And these continue to happen even until now. The sense of security of healthcare personnel and how they refuse to work, and what does that mean for a society, and so many other complex things that she's raising, which we'll address, and I will request participants here to ask questions on, so we can have this be addressed by Dr. Mishra soon. But I would like to now call upon Dr. Biraj. He is a leader epidemiologist and a public health professional at Dhulikhel Hospital. Dr. Biraj, if you would please continue with your presentation and context setting, then we'll do a round of discussion again on other issues as we follow. Thank you.
Yeah, thank you very much. Namaste. I'm from Dhulikhel Hospital, Kathmandu University School of Medical Sciences, and I'll briefly highlight upon like our experience in terms of engaging the stakeholders. I will share a short link, a 3-minute video link of the activities that we did from our institution, so that I'll not need to repeat those. I'll share the link in the chat box in a while. I've always wondered what drives people and communities. Is it logic, rationale, love, hate, instincts, comfort? What is it that really drives people and the communities? And the answer is, well, I don't know the answer. Maybe it is a mixture of all. As a public health professional, the whole experience with COVID-19 has been, in a way, very enlightening one and a most humbling one. From day one, as much as it was about uncertainty, fear, and apprehension, it was also about hope, courage, and determination. And we've been fortunate to have seen this pandemic from multiple angles and perspectives, from the views of the patients, providers, policymakers, communicators, program implementers, and so on. It is complex, but enriching. It is complicated, but rewarding. I firmly believe now that crises bring the best and the worst of us and steer our societies and evoke the deepest secrets that hide beneath us. So let me explain this in 3 concrete points. The first point is, these pandemics and epidemics, first and foremost, are basically about egos and about ourselves. Our first instincts would be, how to keep ourselves safe, how to keep our families safe, and then about institution, and then about the larger society. And that is absolutely fine. I think there is nothing wrong about it. We are biologically primed for that. But the most beautiful thing is that every single person has a component that is greater than his or her own self. So almost everyone has a component lurking behind him or her. However, this goodness is hidden, uncertain, cautious, and does not come out on its own. There has to be someone, a champion, to get this out for the greater good. And my third point is that, as the educated, connected, and capable professionals in our own fields, it is our responsibility and a moral imperative to stand up and use our collective efforts, to bring the best out of the people, around us from our communities, to help them unleash their potential. I think that's the most important one. At Dhulikhel Hospital, Kathmandu University Hospital, we attempted to take the leadership role in waging a comprehensive fight against COVID-19. So we did not limit ourselves in just focusing around handling the COVID-19 patients in the hospital. We wanted to go a little bit beyond that. So from the very beginning, we tried to identify the people, the stakeholders who could be brought on board, in various ways, and get them involved in various capacities. I'll give you some examples, and I think that will shed some light in terms of the importance of stakeholder engagements. In the first wave, to set up the triage, and even to set up an isolated isolation center within our premises, we worked exclusively with Army. And they helped set up our triage and a lot of other things in partnership with our team members. Then, as Dr. Sangeeta mentioned, and we had issues, a big shortage of sanitizers and disinfectants. What did we do? We worked with Kathmandu University School of Science, and we used their lab, their manpower, and we collaborated with them in producing and also ensuring quality of our own sanitizer and disinfectants. In the second wave, when we had terrible crisis of oxygen, it was probably one of the worst days of my professional life. So during those times, what we did was, we worked with our School of Engineering at Kathmandu University and helped, and we collaborated with them in terms of optimizing the functioning of our oxygen plants that were existent at Dhulikhel Hospital. In the same way, from day one, we collaborated extensively with the local municipality, the local wards, the local health authorities in terms of testing, contact tracing, and also devising public health strategies to communicate to the local communities. We have been working from day one very closely with them. Even now, in the second wave, there's a huge outcry that the testing in the communities is really low. What we have been doing, in the second wave is working with the local communities and local health authorities in terms of expanding the testing to the rural communities as well. We've been working with private sector, for example, with the telecom companies. For example, we worked with Ncell in creating a national level hotline where the patients who are tested positive can get advice and can be followed up, till they are fine or till they need a referral. We've also been working with some business sectors in generating some resources. And in the same way, we've also been closely working with philanthropic organizations, embassies, Rotary clubs, Lions Club, and many other these organizations, for gathering whatever support we could garner from them. In the same way, we've also been collaborating internationally to philanthropic foundations, universities, and also other organizations, in supporting us in various ways. We have also been working very closely with the government in developing specific policies, plans, and also protocols. We've also been working extensively with media, various media groups, in crafting the right messages for the public and in disseminating the messages to a wider audience. What did we achieve out of it? In summary, I think we have done quite a lot, but it is still, there is a lot to be done. More than 1,000 patients treated, few thousand patients supported through home isolation support program, almost 50-60,000 tests done already, developed some national level guidelines and training protocols, supported government on various policy aspects, and we also set up 18 isolation facilities in our rural outreach centers, especially in the second wave when there has been a big outbreak in rural communities. Now the question comes, how do we do this? How did we do this? The first and foremost point is we need to get out of the box. We generally prefer to remain in our comfort zone, in our own professional silos, in our own institutional silos. So we need to get out of that, and we did manage to get out of that. That's why we could work with people from very diverse backgrounds, and we had to speak the language that they didn't understand. We had to listen to the language that we did understand. So we had to find a common ground to talk with people from these different backgrounds. And the second thing is we had to organize ourselves in handling this. We had to allocate dedicated team just to oversee communication. We had to allocate a dedicated team just to write proposals, a dedicated team just to handle media. This was not within our institutional system. So we had to change these tasks and roles and responsibilities, within a very short time. And another most important part is we had to forge partnerships with institutions, with entities, with individuals, that had not been in our loop in the beginning. And we had to be very open about it. Now, why did we do this? We could have done the very minimal that we were supposed to do, that we were obliged to do. But what we felt was that it was a moral responsibility. It was a moral imperative, because we have to be the voices for the voiceless. Because we are serving these poor patients, most of the poor patients, that end up in our settings. Most of these rural communities with whom we are working, they will never ever be able to reach to a fancy hospital in Kathmandu. Never ever. So we have to be the voice for them, and we have to reach to them. If they cannot reach to us, we have to reach to their doorsteps. I think that was the founding principle that helped us guide through this whole crisis. Now, finally, what next? As Haruki Murakami said, when you come out of the storm, you won't be the same person who walked in. That's what this storm is all about. And I think it's a very beautiful sentence. And when we are out of this pandemic, we will be very different than before it. And I take it in a very positive way. I firmly believe that by the end of this crisis, we will have elevated to an altitude higher than where we began. Our health system will have been much better. Our disaster response system, community cohesiveness, innovative approaches will be much better. So our aim now, especially with you all, should be to harness all the efforts we have put into it till now and make us stronger, and not just go back to where we started before the pandemic. So let us work on that. There will be more disasters in future. There will be more pandemics in future. Let us aim for something bigger. Let us create centers of excellence. Let us create collaborating centers. Let us create academic programs and training programs in areas of laboratory investigations, epidemiology, clinical care, communication, mental health, social science, vaccine technologies, disaster management, and whatnot. I think it opens a huge opportunity in terms of expanding our horizon and strengthening our system, our people. Let us work on that. With all of you, we have to find a way, to really strengthen this academia, government, private sector, and communities collaboration. For example, at our center, we are working to establish a dedicated pandemic center that brings together these different domains, so that in future, when we are going to handle scenarios like this, we will be far better prepared, and we will also be in a position to develop new cadres of people who will be handling this pandemic, in coming days. So lastly, what I would like to say is, is just paraphrasing what Winston Churchill said. When we survive together through this pandemic, I think future generations will say this was their finest hour. So let's work together. I'm sure there are a lot of avenues we can explore together. Thank you very much. I'll share a short video link in chat box. Please find a time to check it at your leisure. Thank you.
Thank you, Dr. Biraj. That was very enlightening. And thank you for bringing this idea of the ecosystem approach, right? Like we were caught by surprise, the world was caught by surprise, but how do we engage stakeholders across the system to the service of communities that are deprived, that are of low economic opportunities? How do we make systems work for us? So thank you so much for highlighting that. It's really, really important. I request the attendants to ask more questions about to Dr. Biraj in the chat box about this idea of an ecosystem approach, and does it really work in Nepal or not? Because that's an interesting point. And to come to something he said about the continuous trajectory in which we are, where we will see more pandemics. So how do we prepare, right? Like, what is our preparedness going to look like? Thank you so much. Of course, we have seen a lot of importance on testing, the laboratory end of things, the research that needs to happen, the assessment of the disease. And Dr. Sri Krishna Maharjan, our next speaker in line, is exactly that at the Patan Hospital's microbiology team. Dr. Maharjan, if I can call you to please take over the floor and share from your point of view the challenges being faced at that level by your hospital, but also Nepal in general, for its research capacity in biochemistry, in molecular biology, in laboratory sciences, laboratory infrastructure, how you are coping, what was Patan Hospital doing, where do you see the gaps and needs? Thank you so much.
Hello, namaste everyone from Nepal. Good morning outside those who are in US and overseas. This is Sri Krishna Maharjan. I have been working in Patan Hospital since 2013 that I returned from US after 12 years of stay in New York and a few years in University of Toledo, mostly into research, doing laboratory work with genotyping and sequencing and molecular biology, a lot of things like that. So whatever I learned during the Fulbright study, master's in New York Medical College, then went to PhD in New York Medical College, and then postdocs. While coming back to Nepal, and sooner I joined Patan Hospital as a faculty in biochemistry and molecular biology, and I immediately started teaching there. But as this pandemic arrived, then Patan kind of hospital sort of prepared, like the devastating earthquake about 6 years ago. We very well on forefront with our students, with our faculties, with our health workers. We kind of dealt well with that, and we sort of learned that how to cope up with situations like that. And when this pandemic also arrived, the initial days were very tough and very scary, listening to the news and coming in the media. And it took a while to arrive in Nepal. And though the neighboring country just across the Himalaya to China in Wuhan, but it took a time to come from the flight and then through India and towards the open, as explained before, to the porous border, ultimately through the southern border, arrived to Kathmandu. So Patan started with 5-bed COVID-19 ward with very limited resources. And the first thing Patan is prepared is Patan kind of knew that there will be immediate shortage of the resources like PPEs. So we kind of at Patan, there are more than 1,200 staffs at Patan, and kind of the management system is started preparing PPE our own. So the development of PPE was one of the major breakthrough for the successful management of COVID-19. And then also through the CDC programs and also the WHO in the media, we also started trainings conducted for the staff well before this thing came to Nepal. Trainings help in increasing competence, thereby increasing confidence. And also we kind of waste management system were strengthening waste management system was one of the major area of safety of health worker as well. And also the facilities like in-house food made in the kitchen, and the internet service was provided. So we kind of sort of prepared to handle this like we did before the devastating earthquake. And also the supply chain, demand chain, supply and demand chain was analyzed and mainstay precisely. And also like Patan had been for decades under the CDC, even before the kind of NPHL, we had a surveillance unit for influenza, and we kind of have a molecular lab equipped with one PCR and few hoods. But we were in a way before even this pandemic arrived that we were going to upgrade that existing influenza surveillance unit molecular lab. And while we're doing that, this pandemic arrived, and then we started running our molecular laboratory as well, doing PCR tests, started PCR tests manually in the hospital itself. So that is one of the major things we started doing as the patient started following in, we started doing the testing as well. And so far, till date, we have done about almost 50,000 total testing, and about more than 12,000 positive cases we have already reported. And these are the major things. And also like antigen testing was also breakthrough during the period when we were in dilemma, like sometimes we have to immediately admit the patients, and waiting for PCR and doing manually takes almost about 6 to 8 hours, or sometimes even a day when the testing is, the volume is very high, like last time. Then also like after testing, then one of the other thing the Patan started is COVID-19 vaccination, and it was well planned inside the hospital. Vaccine was done, a system was developed and implemented. Another very major thing was the activation of the higher commanding system inside the hospital incident command system consisting of incident commander, including registrars, and all of these activities already started. So till now, we have kind of successfully dealt with whatever the patients coming in there in terms of admitting the patients, treating, testing, and also, but recently, like due to this shortage of oxygen, as started very high amount of patients to Patan, things have not been very easy, and also activation of some merging with some social involvement, like Feed the Hungry program, and raising the fund, and then also started contributing some filled up cylinders from nearby, and also helping to pay for the cylinders filled up, and like that in somehow the other way we are helping. So this is about the part on how it dealing with the current situation. Things has not been easy. It is very tough, and we're still coping. And a lot of staffs became positive, but still with difficulty we are managing. And since my background is mostly on laboratory side, so saying this as background for Patan Hospital, how it is dealing with the COVID-19 current crisis, and also the dealing with the infrastructure. From laboratory point of view, like we are still struggling to scale up the testing from the Patan. Like Patan, as a lot of you know, it is a tertiary center, public setup in Lalitpur district. It is the hub hospital nominated by the government, and there are several satellite hospitals, private ones like that. Then as the patients start flowing in the Patan, then slowly it gets filled up, then we activate and send the patient to other satellite hospitals, and then there is kind of chain we are dealing together and managing in this locality, and coordinating with the private local hospitals as well as with the government, and also dealing by itself, running a lot of things like that, including from testing, treating to vaccination as well. And from the laboratory side, like a hospital, a tertiary center like Patan Hospital should be scaling up, doing testing, not just 200, several hundreds, but it has to go up. So with limited resources, manpower, frequently getting positive and like that. So it's been very difficult. And also the resources of other things. So getting automated system, we are trying to get into the automated systems very soon. And the scale up will be to a standard. And also the another requirement, after testing, the requirement is to, currently the situation is, there is a lot of things that variant of concern, variant of interest, new variants of rumors circulating around. So not only just the testing, whether it is positive or negative, sequencing has also become very important in Nepal. And to my knowledge, there are very hardly any sequencing centers, maybe one or two, one in Dhulikhel and one maybe the private sector trying to sequence. But Nepal is struggling to do that, and frequently from the government sides has to send the sample overseas, get sequenced, and taking time. And even recently in the media, there is a rumor going around that the Nepali variant, circulating around. To disprove that, also we need, good sequencing center, and then say that yes, it is there or it is not there. So this is also very important. So I'm also very interested, to have set up a very state-of-the-art, well-developed technology for sequencing as well. And not only sequencing, like we are now currently slowly, as the volume is slowly coming down, unlike last month. So trying to collaborate with, other institutions and foreign bodies to come up with like how the vaccination has been effective, like those who have got 2 vaccines of Covishield, talking from only from our side within the hospital, like almost more than 1,200 staffs have been vaccinated. And it is a good thing there's hardly none of the staff has been, there is a death cases, there is some cases, mild ones, but those who have double vaccines, there is none that they have to go to, go for very, there is no death cases. So the vaccination has proved, double vaccination has proved that it has worked a lot. So like previous speakers, Dira said that, yes, we can also have some partnership or some teachings or some capacity building in Nepal. Like-minded people come together and do some to work towards not only the testing but also sequencing, and also ultimately, check these stored samples if any new variants are there, and also go for vaccination, development of vaccination, because currently vaccination is so important. If we could just get vaccinated, full dose to everybody, even the third wave or fourth wave, we will be very much secured, as the double vaccination has recently shown the records. So I'm also would like to call upon the local, regional, national, or even the overseas international bodies and communities, the experts, to help us come up with kind of technology transfer, capacity building, and come up with how, have a setup where we can do for excellence for testing, not only testing, but also sequencing, as well as develop some kind of vaccination of our own, so that we don't have to worry so much in the future, in coming days. So
thank you. Thank you.
Uh-huh.
Okay, thank you, Dr. Moharjan. There's a lot of questions about vaccination sequencing and things like that that are coming up that I'm sure Dr. Philip will attend to in a while when we come around to asking you questions. But thank you so much for highlighting the fact that Patan Hospital has always been very exemplary in its own management, even as an autonomous system, and one that charges so little fees to the public, it's affordable care, but excellent care. But how you're talking
Actually,
about—
it is free.
Yes, it is free.
It's all free in Patan.
Okay, thank you. But how the earthquake, you said, seemed to have prepared Patan for management of a following crisis. And that is such an important lesson. And if, disaster resilience is something that people are interested to ask questions about, please go ahead, because there seems to apparently be evidence of the fact that even preparing for something as physical as earthquake disaster has, prepared Patan to handle microbiological sort of disaster as well. Obviously not fully, and we're still looking for collaboration on the scientific front for laboratory sciences, but at the same time, people are attending to that very responsibly. Thank you so much, Dr. Moharjan. Next up, I will ask Dr. Archana to please present to us more of a contextual scenario on Nepal and the impact on public health from your point of view. Dr. Archana, please join us.
Sure, thank you. Am I audible?
Yes.
First of all, I really like to thank the organizing committee for this opportunity and bringing so much of thoughts and inputs together in one platform. It's really amazing. So as far as public health and COVID-19 is concerned, I'm sure it doesn't need much explanation. It's very much correlated. But today I really want to focus on two major things. First is the inequality that it has shown us, and the second is the partnerships and its strengths to address any kind of public health emergencies. So to begin with the inequality, personally, I have never experienced, I've never witnessed, or I've never visualized this kind of inequality so much firsthand ever in my personal and professional life. This has been a great eye-opening experience for me in terms of how health inequity has played a major role in how COVID-19 has been addressed, has been managed, or and also the mitigation strategies of COVID-19 has impacted and affected the people, not just in Nepal, but all around the world. For example, we started with a very simple idea. We just wanted to prevent the transmission of COVID-19 in Nepal, which is a very, very important, which was very concerning, and which was very relevant at that point of time. And that led the government to shut down everything. But the impact of it was distributed very unequally, and that came up very vividly in front of us. So a lot of migrant workers at the border in India as well as in Nepal had to stay there for months and months without the government of both countries taking care of them, compared to people who were traveling from other high-income countries. who were arriving in the international airports had much more accessibility to the information, much more concerns or much more care received by the concerned authority, even though the proportion of the people who were crossing the lands and who were flying into Nepal were so much different, and we could clearly see the impact of socioeconomic status of on how we as a public health professional and a country as a public health authorities dealt with these two situations in Nepal. And I believe that public health is also a humanitarian issue, and what this brought to us was like we as a public health student and as a public health advocate, I have been talking about it forever, hearing about it forever, but to see and to experience it firsthand was something very path breaking for us as a professional, because now from here on I really want to contribute more towards bridging this gap of inequality, and COVID-19 has done that for me personally. Second, I guess for me the biggest lesson was partnerships. Never have I ever in my entire career talked to so many people in that point of time who had one single agenda, who were so willing to coordinate and who were so willing to collaborate without self-interest. And that's something I have never heard of. I've never seen before. When we talk about our professional career, we always talk about where do I get this done for me, for my career. But when it came to for the people, how can we prevent these many deaths? How can we prevent these many people from getting infection? And the number of volunteer people that are working in Nepal are uncountable. From experts to students. When in the initial phase of COVID-19, when we had to do the surveillance, we only at that time we only had the cases, and we were collaborating with them, and we wanted to do an active surveillance of the symptoms of COVID-19 among those who came to Nepal. At that point of time, we had only 5 reported cases, and we put up this advertisement on website. Who wants to help us volunteer to save the lives? And the overwhelming response from students and heartwarming. Within 1 week, we were able to set up a surveillance system. 400 volunteers were calling the people who crossed the border lines. We were able to call 6,000 people in just a matter of 7 days. And we were able to find out where these people were located, what could be the next area where we have to investigate more on this epidemic, where is the area that we need to keep more eyes on. Not just that, like the profit-making organizations came forward and they joined our endeavors. In no time, we were able to map out the people who were crossing the borders in Nepal, and that information was supplied to the COVID Crisis Management Committee to prioritize the testing area. And it all worked out of partnerships. Within 2 weeks, we were able to set up an electronic tracking system that was in a month endorsed by the government of Nepal. Well, it did have its own limitations, but it could not be implemented as widely as we had expected. But all of these IT companies, they came together with 200 people to volunteer, and then they built the system in 2 weeks, completely free of cost. And the amount, and this meeting almost like 10 new people every day, and we were all like-minded. I don't know how it happened, And in that time of crisis, I felt like that kind of collaboration and partnerships that we saw in public health sector of Nepal, it's commendable. The public health experts, both Nepalese and non-Nepalese from all over the world, are connected in one single Viber group. We have more than 100 experts in a Viber group, and it has non-stop messaging, and everybody's talking about what are the next big strategies, could be the next big strategies for Nepal. So I think that for the next forward stepping for Nepal is to work on the inequality. We should not forget people who are staying in the remote areas, who are not getting tested. Like 3 weeks ago, we heard 10 deaths within 1 week in a remote village of Nepal. A whole village is getting symptomatic, no testing done. There is no treatment centers equipped with trained human resources in rural remote areas, even though we are getting anecdotes of how the epidemic is spreading in those areas. So we really need to prioritize our agenda. Of course, we need to get the whole of the Nepal and its citizen involved, but I think we should wisely prioritize that and make sure that not just the haves get everything. We also need to prioritize, and we need to give more emphasis to reach out to those who are not reachable. And building on the partnerships, I think this is the time that we should really come up with single and strong voice in two areas. First is the international arenas, and I'm sure a lot of like our previous speakers have already talked about vaccination, and that's key. I would again emphasize on that. We really need to make sure that each and every eligible Nepali would get our vaccine. It's also like this is the vaccine distribution all around the world is a big example of how inequity exists in the world as well. So I think that while these conversations are going on to get the vaccines to everyone, we also need to focus. We should continue to focus on that, to get the vaccines in Nepal and to make the vaccine reach to whole country. And Nepal has a really good vaccine distribution mechanism. It has been a leader in distributing and immunizing vaccine to children. Like it has always outperformed the vaccination campaigns. Vaccinations are really well taken in Nepal. It's with less is very less stigmatized, and moreover we have all of these distribution chain already existing with the cold chain facilities available, so we can do it. I am sure that we can, if we get the vaccine, we can vaccinate it each and every one within very short period of time. And we also need to have our voice together for prevention of further damage in terms of more transmission at the community level, as well as in terms of reducing the mortality. So to prevent the more transmission rates, to get it down, the vaccination is key, of course. However, the other big thing that we are missing out in has been a very disappointing as a public health professional in Nepal is how we are tracing the contacts and testing and isolating them. The pivotal strategies that a lot of countries have taken, and if we look at the success stories before vaccine, that's the only strategies that has shown to have worked in many countries that were successful to control the transmission. And we really need to strengthen that in Nepal. Nepal government has the epidemiologic and disease control division has prioritized it, but has not been disseminated well in terms of implementation in Nepal because of one, I mean, if I have to point it out, I would say the one big challenge is unfortunately the federalization that happened just before the pandemic arrived. So the health system was decentralized just a few months before the pandemic arrived, and there was no very specific chain of command to deal with this kind of pandemic. And so also to emphasize again on the partnerships, we really need a very strong partnerships within country, within different federal system, like local government, provincial government, and central government, which has been largely missing in Nepal. And that has been very much challenging to implement, not just the risk communication or contact tracing, like overall a strategic action plan of COVID-19. And a third partnership would be to collaborate within the professionals and the partnership between the experts, like experts like academic experts, like experts who are not within the government agencies, to come together and work together, because a lot of times we are talking to different agendas, like we are telling two different stories and coming up with two different solutions. And I think we really need to build a strong platform to materialize everything in as a one big agenda, and just like focus on solving this problem in a collaborative and a unified way. So I would like to end it here, and very happy to welcome comments and questions, feedback.
Yes, thank you so much, Dr. Archana. Your presentation was very, very important. The issue of equity and equality, the service, and almost citizenship also being nearly two standard or maybe multi-standard, right? And then there was a question from one of the attendants, which I think will be raised by Dr. Philip, about how did the Dalit fare in all of this? What are the implications for the really underprivileged and marginalized? Really, really important questions about equity crisis in Nepal to access to public health. But your presentation also had message of hope on how, when you're organized and we call on citizen action, a lot of people join forces to gather critical information, right? So Nepal has an incredible, incredible population of youth that really spring to action in major crisis, and all of the frontline workers who are volunteering, who are exceptional, are a whole other chapter that we should definitely work with and create a webinar around. But thank you so much for that wonderful presentation. We invite questions to Dr. Archana, of course. But in talking about the service to the really, really vulnerable, Dr. Sangeeta Mishra wanted to bring up her experience at the maternity care hospital and the lives of postpartum mothers or pregnant mothers and infants, you know, babies in Nepal, right? Where are they? And in Nepal, as you all may know, maternal mortality is really, really high. It's almost at epidemic proportions, I would say. And there's a lot of action happening with the support of a lot of collaborators from the international front as well to prevent that, and government also focuses on it. But how does Dr. Mishra see, and how has she managed maternal health at this time of crisis as vulnerable people's health maintenance? And what about the infants and the children of Nepal? How do they fare at your hospital, but what do you see as a real need on their behalf? Quickly, Dr. Archana, like 3 or 4 minutes, and then we will get on to questions and Kirtiji's statement.
Thank you, Rishuji. As Dr. Archana already said about equity, I just want to point out one simple thing, that whenever a disaster or pandemic or even epidemic happens, it affects women and children very differently than the general population. So whenever we make policies, like in this case, like when COVID policies were drafted, nobody thought of women and children like as a center. So they were actually very much sidelined. So why I'm saying this, because the messages were drafted in a way that you don't need to get out of the house. You need to stay inside the house, and there were no clear messages of about getting your general antenatal checkup or your family planning and safe abortions. So there was a very much confusion among women whether to go to the hospital or they have to stay at home. The women who had access to the system, they could call or they could talk to their private doctors. But as the women who were from the lower socioeconomic group, who could not access or who didn't had a smartphone to scroll or who couldn't call, so they were the women who were hit hard in this pandemic. And we had so many cases where there were delays. So where all these delays happen, so the first delay was in deciding whether to go to the hospital or not to go to the hospital. So the delay on the women and the family side. The other delay was in transporting the women. So there were lockdown, but nobody thought like, how will these women travel to the hospital? While right now, when I see my hospital, my OPD attendance has decreased by 50 to 60%. So these women, they cannot travel to the hospital. I'm not very sure whether they are getting checkups or not. And then the third delay was whether if they could reach the hospital, whether that hospital was providing services or they were turning away the women. So the women had to go to so many hospitals, then coming to a hospital where they could get the services. So in this regard, we just did a quick research and we just found out that institutional deliveries decreased all across Nepal. And when we saw about the abortions were like the women who needed abortion, the proportion decreased by 34%. That indirectly means that whether either these women resorted to the unsafe abortions or they are carrying unwanted pregnancy, which is again a psychological problem and has economic implications as well. Similar things happened with the family planning. The use of family planning decreased by around 39%, which means that all these women had high chances of getting pregnant. I just wanted to point out one more thing, that in Nepal, 90.5% of women, they work in informal sector. With COVID hitting, all this informal sector was closed and all these women were bound to stay at home without any economic support, and which has led to rise in gender-based violence, and again unwanted pregnancies are coming up, because once this lockdown was lifted, we could see all these women coming with second trimester and asking for second trimester abortions, which is very much dangerous for the women. Similarly, if we see at the newborns, those who were delivered at the hospital, the admission for the newborns, sick newborns, suddenly increased from 6% to around 9.5%, which means that they were either coming late to the hospital or they were not having adequate care. So in this regard, everything, all these our indices, which is like of maternal mortality, that has like badly affected. And in this wave, in second wave, we are finding much more rise in maternal mortality. So I think in last 15 days, we have around 12 maternal mortality all over Nepal. So you can say every day a single woman is dying because of this COVID and pregnancy complication. Similarly, we found out that there were high incidence of depression and anxiety in the antenatal women, as well as more in the postnatal women. So the psychological aspect has also been affected. So I just want to say that these women are disproportionately affected.
Okay, thank you so much, Dr. Mishra. That these are all very, very important points, and I'm sure people have follow-up questions for you as well. While I ask Dr. Philip to please collate the questions and moderate the Q&A, I want to call upon one of our other leaders who's joined us since the beginning of the session and our lead organizers, the Fulbright Alumni Association of Nepal's chairperson, Kirtiji, who's been instrumental in putting this program together as well. He is himself representative of the government of Nepal, but also local government, and works with the Kathmandu Metropolitan Council. He's a reputed architect. There were questions about built environments and how it should be COVID responsive. But aside from that, I would just want to call on Kirtiji to set a context about why we are doing this event and what each of these presentations of our Fulbright alumni at the forefront charts for continued partnership between US-based and Nepal-based Fulbright alumni and global community and friends of Fulbright. So Kirtiji, while Dr. Philip is managing the questions and preparing to lead the Q&A, I want to call upon you to share some of your thoughts, please.
Thank you, Susie. Hello, everyone. My name is Kirti Joshi. I'm president of Fulbright Alumni Association of Nepal. Unlike our panelists, my background is different. I'm an urban planner by profession. And I would like to start, I would be very brief. I would like to start my statement by acknowledging the effort of Dr. Philip in bringing us together today. Years ago, Dr. Philip was a Fulbright scholar to Nepal, and since then, he hasn't lost his connection with the Nepalese society. Now, the reason for using Dr. Phillips as an example, of course, without his permission, is to highlight that the urge to give back to society is what defines our character, our integrity. It doesn't matter which society to serve. It could be a society that we need, or it could be a society that needs us. And with this COVID pandemic, the whole world has become a big, one large society with large society in collective despair, where, as they say, nobody is safe until everybody is safe. As we all know, and also explained by our panelists, Nepal is still struggling with the second wave, and even as we speak, the threat of third wave is looming large. And this time it is predicted that the children will be impacted more. Let's not fail our children who have no idea about coronavirus, no idea about vaccine economy or vaccine politics or vaccine diplomacy or vaccine nationalism, or for that matter, they don't know anything about this webinar also. So let's join hands against our common enemy, not only this one time, but for a long time, because who knows, the next avatar of coronavirus may be waiting outside our doors. We already have so many variants roaming around. In the participants list, I can see many distinguished names from different parts of the world. Fred was telling us that there are participants from Canada, from Germany, and from many other countries. The Fulbright community also includes former ministers, top bureaucrats, professors, scientists, and doctors, among others, doctors like our wonderful fellow panelists. I request all participants, including our alumni members, our well-wishers, our colleagues, to come forward and help defeat coronavirus in whatever way possible. The Fulbright Alumni Association and Fulbright Commission, we are here to connect you to any practitioner or organizer in Nepal, as our members come from different walks of life. And better, you can also directly contact our panelists who have been doing very amazing works. I once again request everyone present here to join hands without losing a second, because there may not be a second chance to save somebody's life. And I would also like to request you to focus on solutions. We discuss mostly on problems, but as there is a saying that if you are not a part of a solution problem, then you are a part of, If you are not a part of solution, then you are a part of problem. So let's focus on solutions. Thank you. Thank you, Riz.
Thank you, Kirti. I think that this event has shown the incredible resilience and strength of the Nepali people and Nepali society in handling a challenge like this. And it is a challenge, and it has to be dealt with. But I admire Nepal and how it's responding and to an existential threat, and it will respond properly. And so it's my motivation in doing it, to help show the world how strong and how good Nepal is. I would like to suggest that all of our speakers unmute their microphones, because when we ask questions, it should be a discussion among a group, not just one or two individuals. So if you could all do that, please. And I'd like this to be a discussion, not a monologue by any one person, because some of these questions, we have a limited number of questions, but they're important questions. I mean, from the first question that we had at the beginning was, do you think that the COVID-19 situation is getting under control? Is it under control? Will it be under control soon? What's your impression? Anybody want to speak? Nobody wants to speak. Nobody has to answer. No, you don't have to answer.
I can go first. Just to be very brief, as an epidemiologist, I'm saying this, it's not under control. How the data that we are seeing right now, we are getting almost 5,000 cases per day. Which looks like the cases has been reduced by 50% from what we had like 3 weeks ago. But I would like to remind everybody that at the peak, when we were in the first wave, at the peak we had 4,000 people per day. So we are not even close to the peak of the first wave. We're definitely not under control. So that means these numbers indicate that our health system is still in a big pressure. The second indicator that we have is now we have much more higher proportion of reported cases from antigen test. That means, and then if we compare this proportion from like past few days, the proportion of antigen test positive is rapidly increasing. So that means that we are getting positive cases from rural areas more. The cases in the rural areas are increasing. That's a very good, might be a very good indicator of that. So at least for 3 more weeks, I don't think we can take a deep breath. We are still on war, and we have to be mentally prepared to face it for next 3 to 4 weeks.
Okay.
I'll just add on to that. So, you know, as Archana said, although the numbers and even the positivity rate is getting down, and the graph also shows it is in the receding phase. What we need to be mindful is that during the first wave, the whole epidemic curve was on a normal scenario. There was no lockdown during the peak period. You know, there was lockdown before the peak period happened. But this time, this whole epidemic curve, you know, it is during the lockdown period. So what we are really concerned now is that as soon as the lockdown is loosened, it is very likely that we will see another hump, you know, before it actually recedes. So by no means the health system should, you know, take a sigh of relief now that it is going. And then another part which she also mentioned is about the rural areas, and it's a black box. In fact, most of the rural areas, you know, they haven't tested, so the numbers and the magnitude of the problem does not come out in the statistics. But you know, the anecdotal stories say that, you know, there are villages and villages that have been really devastated. So I think we need to be very cautious about that.
And to add on, Biraj, like there are many villages, they have this myth that they are getting this typhoid or some other diagnosis is concurrently going on. And so we don't have the correct figure of how many actually people are infected, especially from the rural areas. Yes.
Professor,
Yeah.
okay, go ahead.
Mhm.
Go ahead.
Yeah, from the laboratory point of view, since I myself very much involved in the laboratory side, yeah, like previous speakers already mentioned that still it is hard to say. Our national curve shows that it's almost half down, and also in India it's more than half down, and that's something very much better side. But again, like still I can see families and families with high city values, getting positive, and also the oxygen demand hasn't come down yet. So and also the municipalities now coming into action, doing antigen tests, going from house to house. And like earlier said, the number of positive is going up. And since it is, like very strict lockdown, and people are forced to stay inside, and also the testing has become, kind of limited. So it's still hard to say. So though the curves are coming down more than a half, but it's still very hard to say.
One of the questions related to oxygen supplies, and the question goes, are such critical needs assessed for worst case scenarios in the future, oxygen and other critical laboratory, patient and laboratory supplies for future pandemics? What's the planning for that for the future?
Regarding oxygen, actually government is actually allocated budgets, and there are like many public hospitals are getting their own oxygen plants, and as well as liquid oxygen plant. The problem with liquid oxygen plant is that India is also having this huge crisis of oxygen, and all that liquid oxygen has to come through India. So but still right now we are in a better position of having this oxygen, because initially, as Dr. Biraz was also saying, that there was a ration system on oxygen, and we had to actually wait for our turn to get oxygen cylinders. And then the other thing is, like, government has directed all the hospitals, even the private hospital who are more than 100 beds, to install their own oxygen plant, and government is facilitating in installing the oxygen plant. So I'm quite hopeful that over a period of a month or 2 months, we will be actually, I should say, self-sufficient if the infection doesn't go out of control.
That's wonderful. We have a totally different question from Professor Subodh Sharma, who's on this call. He asks, what mental health is an important aspect to this. What initiatives have been taken to address the forthcoming challenge?
About mental health, I have seen, like, sorry, if someone wants to take this question?
You don't all have to, if nobody can take the question, then you simply don't. But I'm transmitting it. Okay. And I see Professor Sharma is on the line and he's smiling. Okay, nobody wants to take that one? We don't have to take that one, that's fine.
No, I can take that.
Okay.
Go ahead.
Okay. So about the mental health, like Ministry of Health has started some infographics, and there are some messages, and it has started doing advocacy. But the problem with mental health is we don't have a separate line for counseling. Although there are a few hospitals who have started online counseling, like Teaching Hospital has done online
Patan
counseling for healthcare, and Patan is also doing, and some private NGOs are also offering online counseling. But as a whole, it has not come as a programmatic approach, has not been done on mental health. And that is coming as the biggest issue, because even in maternity hospital, when we look at these women, the incidence of postpartum depression and anxiety has increased a lot. So I think Nepal needs help, and it needs further strategies to curb this.
Yeah, just to add on to Dr. Sangeeta, yeah, that is very correct. And mental health has been, even before the pandemic, one of the most undermined areas in our health system. it is not yet very well integrated. So there is definitely a huge need, and I think that's an area people like us should be really focusing in coming days, especially after the second wave that really took a toll, in a very large way in the society.
Yes.
Yeah,
And
not
with
just the
the
patient.
increasing, sorry, go ahead.
I just wanted to add on, like, it's not just the patients, but also like health service providers, like frontliners and other who are responding to COVID-19 are, I think, heavily affected.
I would imagine. We have another question from Gita Rana who asks about human resource management issues and delivering services in the pandemic. I think some of our presentations have just touched on that, but does anybody want to say any more about that? It's getting the staff to actually work on this issue. I think, Sangeeta, you touched on that a lot.
So human resource management was the difficult part. It was like when I was working in the front line, it was the most difficult part for me as well, because the motivation of healthcare staff, and then about their incentive, and then like keeping them in the quarantine was like really difficult. So right now, government has announced a policy of giving 50% of their basic salary to all the health workers. So that is one of the motivating factors. However, government has also announced to take people on contract, so you can actually directly take people on contract. And in the recent decision, we can actually government has said that we can use final year medical students and the students who are in internship and final year nursing student as healthcare staff. So human resource is quite challenging, because once one person gets infected, he or she is not coming back for next 14 or 21 days. So in that way, you need to recycle the human resource, and getting another pool of human resource is quite difficult. And all the hospitals, I think, are under crunch, and it leads to mental health issues as well, because all these healthcare staff, they are actually overstretching themselves. So it is like quite difficult.
Yeah. Any other comments? Otherwise, I'll go to the next question. The next question comes from an person with an architecture and environmental background, who asks, what kind of collaboration or ideas do you suggest we should work on against in COVID? Would environmental or urban planning help mitigate future health crises in Nepal?
So I will take on.
Yeah.
I'll answer that. I answered in the chat as well. I think that was a very good question, and I think not just in Nepal, worldwide, the importance of the physical facilities, proper ventilation arrangements, redesigning office spaces, and also the neighborhoods. It has been hugely undermined. In the overall COVID-19 discussion, and it's sad that amongst the major prevention strategies for COVID-19, we talk about mask, physical distance, and hand hygiene, but nobody talks about ventilation, which has equally, if not more, impact than mask in some instances. So I think there's a huge role, and people working in these areas, especially built environment architecture, should really come up and put forward with these ideas, because others would not notice it. It is just like the saying, eyes don't see what the mind doesn't know. So I think this is a tremendous opportunity. So I think people from that background should really come up, and the world will benefit.
Okay. Other comments?
Just to add on that, I think when we are going back to new normal, and we are already started talking about getting back to school and how school children are so much impacted, and then who are expected to be impacted much more in the third wave. And in this context, I think and ensuring the safety of students in that context would be very important. We have been through the schools in Nepal, and most of the times it's pretty overcrowded, and there's not much ventilation system in place. So I think I think government also has this very good example. It did soon after the earthquake. It surveyed all of the buildings and like all of the built environment in Nepal to see how earthquake prone it is. And I think this is the time to also do that, not just for the COVID-19, but all for the different kind of infectious disease epidemic that we can have in or expect to have in future.
Okay. There's one specific question to about one of the communities, and that is from Stephen Fulmar, who asks about the effect of the pandemic on the Dalit community. Has it been unequally impacted? And it's actually, well, it's addressed to everybody. So if anybody has a comment.
Yeah, I think I can take this. Dalit communities have been impacted severely because there are two dimensions to this. The first thing that if they are getting infected, the access to the hospital is not there. And then with the second wave, when the hospital beds are not available or very people are having difficulty in getting ICUs, Dalit communities, they don't have an access and they don't have a voice to reach to that level. So there has been discrimination on testing and in the admission or in the hospital care, not just because it is very much personally motivated, but just because they are not into the system and there are no separate plan, from the equity aspect, they are not they don't have access to the health system, and they don't have people who could say and then bring them to the hospital or admit them to the hospital. So I think they don't have a voice and they are affected very severely.
Okay, any other comments? There have been a lot of questions about sequencing, and I think DNA or RNA sequencing for the virus, and I think we've addressed that. Their sequences are being deposited in a repository at GSI-Aid, and but it seems that more has to be done in a public health related way to sequencing. Just to lump all those questions in one group, does anybody want to talk about that in terms of that? I think one of us from Patton Hospital may want to. Any comments?
Yeah, yes. Regarding sequencing, yes, only 2 centers, one at Dhulikhel and one that the private sector is doing, but very limited. I think there is deposition of about 95 so far from Nepal alone, and more will be coming up. But that is very, very less, in terms of the so much cases coming up. And also there is a recent rumor going around about calling, Nepal virus and like that. And at Pardon also, we have all the samples, the RNA extracted samples we have in the freezer lying there. And we have collaborators coming up, for sequencing. And at Pardon, we are demanding that we should have a capacity, build up, and possibly, we are going for a system where we can do by ourselves, not immediately, because it demands a lot of money and a lot of resources and a lot of expertise. So it takes a while. But while waiting for that, there are collaborators who will go for it, and we have written proposals and submitted to concerned authorities demanding that it will be done. So we'll see how it goes, and definitely it will be very expensive, and we need expertise to come together and to work on it, especially when so less is being done, and more has to be done to say that what exactly is going on. Unless we do it, we won't know it, and it will be very important, the breakthrough, the infection coming up. And we are also at Pardon, few professionals coming up together, analyzing the data that how far the double vaccination so far done, at least at Pardon hospital workers have been so far going on. and assessing that also. I think there is a review article already on Pattern Journal. People can go through that. And also we are analyzing the data that how effective these vaccinations have been. So things are going on.
Okay, we have to close this event off. It's unfortunate. It would be great if we could do it for much longer. I think all of us agree, but it can't go on forever. Let me put in one last question, and it's a very simple one. What percentage of the population has been vaccinated in Nepal? Does anybody know?
I think it's very less, 10%.
Yeah.
Yes.
Vaccination rate in Nepal, it is just 1.27%.
Which is
Just 1.27% who are totally vaccinated, and around 1.6 million people are waiting for their second dose of Covishield.
Yep.
And till now, like India was supposed to deliver Covishield, but there were some technical issues and some political issues. They're not delivering. So right now, 1.6 million people are waiting, and they are almost like they are due for Covishield in next a week or so.
So we can reasonably call on the vaccine manufacturers to keep Nepal very much in mind when it comes to distribution of vaccines. And I think we should all do that. Look, we have to end at some point, and that point is now. And I first of all like to thank everybody who has been speaking here. This has been a wonderful presentation, wonderful session, and not because of my doing, but because of your doing. And I'd like to also thank all those who attended. Thank you all for coming. This is late at the evening and now in Nepal, and it's time. That's one reason we have to stop. Okay. So thanks so much, and Carrie. Well, I personally wish everybody here all the best, and it's a difficult time. It will be difficult for a while. So thank you again.